we do have our speaker today that Noelle's going to introduce, and I'll pass it over to Noelle.
Perfect, thank you. So it's my great pleasure to kick off the first speaker of our Stanford PGI Research Seminar Series of 2025. I'm very honored to introduce our esteemed guest today, Dr. Emily Perito. Dr. Perito is a professor of pediatrics at UCSF, where she's also the medical director of the UCSF Pediatric Liver Center. Her research and clinical work focuses on optimizing long-term outcomes in children and adolescents with hepatobiliary and pancreatic disease and patients with chronic liver disease and who also have undergone liver transplant. She is a leading national figure in our field. She directs epidemiologic research aimed at improving access to transplantation, enhancing organ allocation processes, and improving waitlist outcomes for children awaiting liver transplant. She serves as the co-chair, the co-chair of the Starzl Network of Excellence in Pediatric Transplantation, where she's leading efforts to optimize immunosuppression across 13 plus pediatric liver transplant centers. Dr. Perito's national work continues to impact our center as we reflect on our own post-transplant immunosuppression and other protocols and how we can continue to optimize them and improve outcomes after liver transplant for all children that we care for. Dr. Perito has made significant contributions at a national level, having served as the chair of UNOS's Pediatric Transplantation Committee and the chair of the Advocacy Committee for the Society of Pediatric Liver Transplant. Dr. Perito additionally leads UCSF's involvement in NIH-sponsored multi-center trials, including the important INSPIRE trial, INSPIRE study focusing on acute, recurrent, and chronic pancreatitis in children and adolescents. Her research explores pivotal areas such as chronic pain management, opioid use, and outcomes after TPIAT. Dr. Perito is a brilliant innovator whose work continues to inspire colleagues across centers while also impacting children on a national scale. Today, Dr. Perito will be presenting her work on collaborating with the community, patient-centered outcomes research in pediatric liver transplant. Please join me in giving a warm welcome to Dr. Perito.
Thanks, Noelle. That was really, really nice. We'll see if I can live up to any of that. People should come in. I know nobody likes to sit in the front row, but you should come in and do that. Thanks, Roberto. Okay, let's see if we can make this work.
And then we're just going to share screen from your Zoom.
Yeah, I think it's gonna. Oh wait, hold on. Let me try. Let me try sharing screen first.
Yes.
Okay.
That and then it'll go
And then start. Okay.
Great.
There we go.
go. Okay.
Okay. All right. This is a little bit more of like a works in progress. I'm gonna talk through sort of some work that we've been working on that's in progress in the liver transplant community. I'm happy to stop partway through and like answer questions if folks have them, or we can discuss at the end. And hopefully I will not talk for the whole time so that we can have some discussion as well. But I'm going to be talking about community and collaboration, patient-centered outcomes research in pediatric liver transplant. Oops, sorry, there's my disclosures. So today I'm gonna try to talk to you about what is patient-centered outcomes research. This is something that I didn't start doing until a few years ago, but I really think has a lot to contribute. And so I'm gonna talk to you a little bit just about what this kind of research is, and then about, we've been thinking about whether we can use patient-centered outcomes research, or PCOR is to save me some words, how we call it, to improve outcomes after pediatric liver transplant. We've been thinking a lot about how we prepare for this in the pediatric liver transplant community and what we could accomplish with this. So what exactly is patient-centered outcomes research? Patient-centered outcomes research is meant to be research that answers questions that are important to patients, that really engages patients and other stakeholders throughout the entire process. So that includes developing your research question, figuring out what your research project is going to look like when do you recruit people and how do you recruit them, in addition to asking them to actually be the participants in your research. And then also actually going back to them at the end with the results of the research, which is something I think we have realized we're not always good at, but that the patients and families who participate are really interested in. It really focuses on what we call comparative effectiveness research, and I'll talk a little bit more about what that is. And it's really meant to produce evidence that can be applied in real world settings to help patients and clinicians make informed healthcare decisions. And the main funder of patient-centered outcomes research is PCORI, or the Patient-Centered Outcomes Research Institute. This is sort of similar to the NIH in that it's a research organization totally funded by the federal government, but makes its own funding decisions, hopefully still, and really focuses on patient-centered outcomes research and comparative effectiveness studies, as opposed to the NIH's focus on more like what's innovative and new and how do we develop sort of new, more basic science and clinical treatments. PCORI is really more focused on like how do we use what we already know better to help patients and clinicians in decision making. So patient-centered outcomes research specifically aims to ask and answer some kinds of questions that matter to patients and caregivers, as well as you guys as clinicians. Things like, given my personal characteristics or conditions or preferences, what should I expect will happen to me? What can I do to improve outcomes that are most important to me? What are my options and what are the potential benefits and harms of those options? And how can clinicians and the care delivery systems they work in help us make the best decisions about my child's health and healthcare? So this is, again, not that sort of totally different than what we're trying to answer in more traditional research, but I think importantly, PCOR sort of starts with these questions at the fundamental of every study design, and tries to make sure that each kind of both the study question as well as what you end up with helps to answer some of these questions in real clinical caretaking. So patient-centered outcomes research projects are usually what we call comparative effectiveness studies. And comparative effectiveness studies are really meant to compare the outcomes, which, you know, we know, especially in transplant, but in most kinds of medicine or endoscopic or other therapeutic options, really include both the benefits and harms of two or more approaches to healthcare. And they are usually trials that compare two or more treatments that we already use in practice. And then they intend to focus on trial outcomes that really matter to patients, family caregivers, clinicians, or other healthcare stakeholders. And this is, again, one of the really important parts where that stakeholder engagement has to happen before you design the study, because you have to make sure that the outcome you're measuring or what we are trying to improve really matters to the people who are going to be making these treatment decisions. So I'll talk to you about some of the discussions that we have attempted to have with our stakeholder communities to try to figure that out. Here's just an example of sort of something we might run into that could be a comparative effectiveness trial. And again, this isn't running now or hasn't happened, but just to sort of envision what this could look like. So a PCOR question for a comparative effectiveness trial could be something like, when a child is 2 to 5 years after transplant, right, in that like maintenance stage after transplant, is it better? And in transplant, it's always, we have to think about, is it better for the liver or the child or sort of the combination of them, to just keep them on tacrolimus with kind of a moderate trough of 5 to 6, or to change to a lower tacrolimus dose and add sirolimus. And so this is what the treatment arms would look like. You have a study population of kids with liver transplants who are just getting tacrolimus, and you have a patient, another group that has a lower dose tac plus siro, and you look at the benefits and harms of, of those two treatment decisions. So this is a decision that we make all the time, right, for individual patients. And so it compares two things that are already really done in clinical practice, but we, at least in the sort of pediatric farther post-transplant literature, have never really looked systematically at when one thing or the other might be better, and what about it being better is really the most important to patients or caregivers. So that's just one sort of example we could think about as what a comparative effectiveness trial might look like in our setting. So the question we started with a couple years ago was, would PCOR be helpful for improving outcomes after pediatric liver transplant? What could we accomplish with it, and sort of how would we do that? And so now I'm going to talk to you about like the process that we've been through and kind of where we're hoping to go as a first step for a comparative effectiveness study in pediatric liver transplant. This work has been done under the auspices of the Starzl Network for Excellence in Pediatric Transplantation, of which Stanford is one of the founding members, along with UCSF and the 14 additional centers listed here. And the goal of this network was really to improve outcomes and quality of life for every child who needs or gets a transplant, and to really try to do it in a collaborative way where we're creating and sharing best practices together to try to solve problems in pediatric transplant. And so I think having this network to work with, in which we could really have a commitment from folks to try to share practices and be transparent about what we're doing, and then work together with stakeholders that were not just the hepatologists and surgeons from the beginning. That's sort of a founding principle of this network, as in many of the other learning health networks that you guys are familiar with from GI, like the Improve Care Now network, which is kind of one of the models that we've thought about. So the work that I'm going to talk about has really been done in collaboration with these centers as a part of this network. We started with thinking about in our community, what could patient-centered outcomes research look like and what would people want to do with that? And so PCORI has a mechanism for what's called engagement awards, which is not to do a comparative effectiveness trial, but it's a 2-year funding mechanism where they ask you to sort of help prepare your community to do this kind of work. And that includes education for patients and families, as well as education for our providers about how you do this kind of work, how you form a collaborative team, and kind of what you might want this to look like. So we did this over the last, over sort of 2021 to 2023. We called it Partner, Patient-Centered Research and Transplant, Engaging Families and Recipients. And here's the list of the sort of lead team that helped us do it. Melissa McQueen, Jen Lau, and Elizabeth Eisenberg are all mothers of pediatric liver transplant recipients. And then you guys may be familiar with Jim Squires and George Mazariegos, are both at Children's Hospital of Pittsburgh. Jim's a hepatologist and George is a surgeon. And then CJ Confair helps run the STARS network. This is what the project looked like. Again, it was a two-year project. And we combined a couple of things. PCORI has their own curriculum about research fundamentals that's really pretty accessible, whether you have any kind of research background or not. And then we wrote some surveys about life sort of on the transplant journal and tried to help people connect their own experiences, either as a transplant parent or recipient, or as a provider of transplant recipients, to what could end up being like ideals or priorities about how research projects happen or what research questions might be. And we came up with 5 different modules that we called learning and feedback modules. Each one of them looked at kind of slightly separate question and had some like teaching component or education about what patient-centered outcomes research looks like or how these different questions apply in it, and then asked for some feedback from people. And we did them as kind of a combination of methods. We started with doing it as like a self-guided module where people through an app or a website portal would kind of click through the education and then answer a survey about it. We ended up doing some of them also through focus groups where we would talk through some education and then get people's ideas about it. And this enabled us to do a couple in Spanish, for example, to do one with young adult transplant recipients. And I think to recognize that, like, actually a lot of the stakeholders really wanted the opportunity both to learn about it, but also to connect with other families that have been through transplant. And so we ended up using more of the focus groups as we got farther in, because that seemed to be what people were most excited about engaging with. We ended up doing this teaching and getting feedback from 219 parents or caregivers of pediatric liver transplant recipients, 21 recipients who had been like transplanted as kids and now were young adults, and 133 transplant providers from the 16 different liver transplant centers. We also had an advisory board that kind of looked at each of our cycles as we went through and helped us interpret some of the information. And we used all of this feedback to put together what we called a partner roadmap for patient-centered outcomes research in the STARS network. And it had some of these sections that you see listed here. We then had a little bit of money built in from the project to put it into a nice looking website. So we had some graphic design folks help us. And we ended up with this website that is really meant to be a roadmap for designing these projects within pediatric liver transplant, or could be adapted to other types of transplant or pediatric chronic disease. We've shared the curriculum now with the PFIC network and with we're sort of working with another pediatric rare disease network that may want to do a similar model. I thankfully have other project leads who know how to do QR codes, so you can take a look at the website if you're interested. But it's really, what we did was like basically take all the feedback we got from people about these different questions and then try to put it into a map that, if you're looking to design a comparative effectiveness study or another kind of patient-centered outcomes research project, you really walk through the website and use that to help you design what your project looks like. So this is just an example One of the sort of early parts of it is about the guiding principles for patient-centered outcomes research in pediatric liver transplant. And these themes of sharing information, focusing on improving the transplant journey, and really thinking about inclusive partnership had come up as themes in the feedback that we gathered. So then we tried to distill that down into questions that people would ask as they were designing a research study and make sure that they answered to really keep things in like a patient-centered outcomes research fashion going forward. Because I think it's easy for us to like start with these intentions, but then get distracted by what we think as the researchers are really important as we write these things. So it was meant to sort of help keep us centered back and make sure that we were answering some of these questions that we went through designing projects. Here's another example of how we tried to go from the feedback that we collected from stakeholders to something that you could really use to design a research project. So we talked to people about like, what are the hopes and dreams of children living with liver transplant? What are you really trying to help your child accomplish? And how do you know that they're successful after liver transplant? And that's an answer that, you know, that's a question that parents can answer and that recipients can answer and that providers can answer. But it also actually helps you think about what a study outcome could be. Because to have a study outcome that is meaningful for patients, then it needs to help answer some of these things. Does your outcome measure whether the child is overall healthy, whether we're minimizing their medication burden, whether they're living a quote unquote normal life, and helped us sort of dig in with families about what does that mean for you for life to be normal? Does it mean no labs? Does it mean just, a sort of limited labs, or what else kind of does that mean to you? And then we came up with just like a one-page thing that we called the outcome scorecard. So it's again a like worksheet that you kind of work through when you're thinking about the outcomes for this kind of study to see do the outcomes that you're measuring, that your research question is going to answer whether it improves or not, does it kind of tie back to some of these things that people said were their major goals of life after transplant? So that's sort of the partner roadmap and what it looks like. And we wanted to then test it and figure out if we could use it to do a comparative effectiveness study. So over the last year or so, we've shifted more into thinking about, okay, now that we've done this engagement work, gotten from patients and families and providers what they think is important and come up with this guide, can we do it? Can we like design and do a comparative effectiveness trial that gets at an important question in pediatric liver transplant? So we've done this under sort of with the collaboration of the Starzl Network's Optimizing Immunosuppression Working Group. As you guys sort of may or may not be familiar with, the Starzl Network started in 2018 at the first meeting we had, which was kind of an adjunct to the split meeting in Atlanta. We had mostly parents as well as providers. And we went through and came up with 4 priority projects that people wanted to work on. What are like the 4 really important topics that affect life after transplant that you think we should be working on? So optimizing immunosuppression was one of them. Quality of life measures was another one, which Vicki has led most of the work on. Kind of perioperative outcomes, which has a lot of surgical stuff involved, is the third. And the fourth one is transition of care. So Jim Squires and I have helped lead the Optimizing Immunosuppression Working Group. And the goal, overall is to think about strategies for optimizing immunosuppression after liver transplant, providing, as you guys know, enough to protect the transplanted liver while thinking about minimizing the burden of immunosuppression on the child and the family. And so we wanted to think about, is this a space where we could do patient-centered outcomes research, and could we apply the partner roadmap to get ready to do that? This is a list of the Optimizing Immunosuppression Work Group. I think there are some other folks on this as well now. And the folks highlighted in orange are the sort of main working group that's been involved in the next stuff I'm going to be talking about. So the challenge we really faced was, how can we work collaboratively towards right-sizing immunosuppression for every child? As you guys know, every child's immunosuppression ends up being quite personalized over time, but we don't actually have an incredibly extensive toolbox from which we work, right? There's a handful of 5, 6, maybe 7 medicines that we all use, but we all use them in like slightly different ways, slightly different doses to try to achieve very similar goals. And so we wanted to think about, and we do it like based on a lot of experience and some collective experience from, reports from UNOS or from the split database over time, but we don't really do this right now in like a rigorous evidence-based way in terms of figuring out what's really the best option for every child. So in thinking about where we might start, moving towards more evidence-based best practices, we decided to start with immunosuppression immediately after liver transplant. We felt like that was the easiest place to assess current practice because almost every center has a written protocol about how they do it. And we also have the most data, right? We have OPTN and split data that is most accurate from the time immediately post-transplant. There's also significant variability in how centers do it, but it's probably the least variable, right? People mostly start with their written protocols and then adjust things over time. And actually, if you look at the UNOS data in the corner over here, the percentage of pediatric patients who get each medicine has actually not really changed that much over the last decade. So it's not like we're all moving in certain direction of like using more or less of one thing. It pretty much, I think people do it how they do it at their center, and that evolves a little bit over time, but not dramatically. The data over here on the other side is one bar for each center, looking at on your left side, steroids versus non-T-cell depleting antibody, that's basiliximab, versus T-cell depleting antibody, that's BIMO. And then on the right side, MMF versus no MMF. And what you can see in this bar graph is that most bars are almost all one color or almost all the other color. And that it just shows that like most patients at a given center get the same thing, right? That this is more driven by center protocol than it is by individualizing the choices for a particular patient. So our goal was to think about, moving from 16 transplant center immunosuppression protocols, where we each right-size immunosuppression based on our own center's expertise and experience, maybe on review of our center's data, maybe on sort of periodic review of the published literature, but mostly everybody was like kind of doing it in their own way, to somewhere where maybe we could create and share best practices to deliver better care and scalable solutions, where we were really thinking about, could we right-size immunosuppression based on our learning health system's collective expertise and experience, and recognizing that this also provides a much larger population if we wanted to look at data for an opportunity to develop more evidence-based best practices that could then be right-sized for individual patients. So this was sort of the goal that we have in mind. How do we do this? How do we work towards right-sizing immunosuppression as a multi-center group? And we thought, through a couple of different models that other areas in pediatric healthcare have used, and decided to adapt a method that has been used quite successfully by CARA, the Childhood Arthritis and Rheumatology Research Alliance. There are other models, right? The pediatric oncologists, for example, they have a culture and an infrastructure where basically every new diagnosis gets enrolled in a multi-center protocol where they have all agreed on protocols, and they very systematically and often in a randomized way, study what works best in variations over time in the COG groups. We didn't think we could jump from where we are now directly to that like highly standardized place, but we wanted to move towards more transparency and sharing and standardized ways over time. So we decided to use this sort of middle ground that the CARA group has found worked for them, and we thought there were some important parallels. They used what they call consensus treatment plans. And these are meant to address a clinical problem for which there is variability in treatment approach and clear evidence for best treatment is lacking. We felt like that applied to immunosuppression immediately after transplant. And consensus treatment plans are meant to be close enough to treatment regimens currently used in the community that they'll be accepted for widespread use by the providers who care for the patients. They're not meant to be practice guidelines, so they're not meant to tell you like which is the best available evidence or what you should do. They're really in the short term meant to reduce variability in treatment. So this is an early example from what the CARA group did. They surveyed people about methotrexate doses and glucocorticoid doses. This was, I think, for like new onset JIA. And they found, just like we had talked about, that everybody used slightly different dosing. Each like pie piece is a slightly different dosing regimen. And they kind of got together and went through a similar process to which I'll talk to you about. And they decided, okay, actually, we could probably like agree to standardize methotrexate down to one dosing regimen, which is impressive. But for steroids, we can't agree that we're all going to do it the exact same way. So we're going to provide 3 different options that people can kind of agree to use. And then you can still choose like which of the medicines that you want to use for your patients. But we're just going to, try to standardize doses so that in the longer term, we could set ourselves up to do something like a comparative effectiveness study, either in observational studies or randomized or non-randomized trial. Now they have worked through both, actually. I think the Improved Care Now network has done, they don't call it consensus treatment plans, but like a sort of a similar process that they've used. So this is how I think of the consensus treatment plan short-term goal, is that like now, we're each of the transplant centers is kind of, we're all at a burger and fries milkshake restaurant, but we're all ordering off a different menu. So like I am at In-N-Out and Noelle is at Wendy's and Vicky is at McDonald's and Mitch is at Burger King. And so we can kind of compare the different options we're using, but like not exactly. And so the goal of the consensus treatment plan is not that we all order a cheeseburger, chocolate shake, and small fries, but that at least we're ordering off the same menu so that my cheeseburger is your cheeseburger, and your strawberry shake is the same strawberry shake as Andrew is ordering. So it's to try not to dictate that everybody has to do immunosuppression the same way, but that at least we're ordering off the same menu. I don't know if that analogy helps you guys, but it's helped me sort of understand what we're trying to do. They're meant to provide a shared menu of options to decrease variability between centers and to really create opportunities for prospective learning, potentially in comparative effectiveness studies, but also for shared decision making. I will tell you that we've really tried to have patients and families at the table for all of these Starzl network meetings and working group meetings and discussions, and they understand, they trust their transplant centers to make the immunosuppression decisions. But actually the idea to them that we all did it kind of differently, but that was just how we did it was quite surprising to them. And they really wanted to know, why do you do that? And so some opportunities for shared decision-making, I think, are important to think about for this too. And then eventually, again, to think about right-sizing immunosuppression for each child. Which of the menu options is actually best for a particular child? And can we be more evidence-based about that over time? The consensus treatment plans are not meant to dictate which immunosuppression you use for a particular child. So as you'll see, as I kind of click through some of the drafts that we have, they're not tied to indication at all. So you still decide what you want to do. But if you decide to use a certain medicine, then we try to say, can you choose one of these 2 or 3 categories for dosing? And then they're not meant to prevent you from adjusting immunosuppression as needed either. This is sort of an overview of the consensus treatment plan development. We are now a couple of years into this as well, and it's been really interesting. The first thing we did, which was kind of innovative in pediatric liver transplant, is we just asked everybody to submit their written protocols for immunosuppression, and we put them all in a sort of shared box. You can go look at them if you want to. And the working group that I showed you earlier spent some time in an Excel spreadsheet trying to distill down what the similarities and differences were for each medication. And then we had a series of consensus meetings for each of the medications that we've attacked so far, and I'll show you what those are, where we met with the immunosuppression working group, and we just talked through here's all the different ways that centers do it. Where do you think we could sort of identify similarities and distill down into some categories? We then, as part of a Starzl meeting right before the split meeting in Florida last year, or no, sorry, that was a separate. Anyway, we were in Florida last year. We met in person and kind of hashed out more specifically what the drafts would look like, and then did some voting on that. We presented it to the network. And then over the last several months, we've gone around and tried to meet with each of the multidisciplinary transplant teams, like the immunosuppression decision makers, at each of the 16 centers to ask, do you think if you're deciding on immunosuppression, you could categorize your patients into one of these categories? If not, why not? What do we need to change? And we've been revising based on iterative feedback for that. So we're hoping to get to the point where we have some consensus on the options in the next few months, and then think about how we might implement those going forward. I'll just show you some examples of what these drafts look like. Some of them have been easier. I think basiliximab is a good example. You can see here some of the just summaries that we put together about which centers use basiliximab and when did they use it, and you can see some patterns kind of emerging. In basiliximab, most centers dose it the same way, which is 2 doses post-op day 0 and 4. And it's 10 milligrams a dose if your weight is less than 35 kilos and 20 if your weight is 35 or higher. That's what it says on the label. That's how people do it in most places, except for in Toronto, where they have a more personalized protocol. They do the weight-based dosing differently. And so we're still figuring out how that's going to look. But because 12 of 13 centers do it the same way, it was relatively easy for us to gain close to consensus that this is how people are going to dose basiliximab whenever they decide to use basiliximab. This is what the draft looks like currently for thymoglobulin. Again, I show you sort of an example of different dosing regimens and then how we try to distill it into some categories that we thought could show us clinically meaningful differences. Right, and I think there's some adjustment here to maybe if you're giving 4 mg per kg versus 5 mg per kg in one dose, people don't really necessarily believe that's going to make a huge difference in outcomes. But maybe if you give it all in, the first 2 days versus you spread it out over 5 days and do monitored dosing, which I think is what you guys might do here when you use it, then maybe there's a clinical difference to be seen there. And we were able to distill the thymoglobulin dosing into basically 2 different categories. And we will ask people, if you're going to use thymoglobulin, whenever you decide to use it, can you sort of categorize your patient into one of these 2 categories? For mycophenolate, it's a little trickier. And so we have a little bit more variability based into the current, built into the current menu options here, where we say pretty much everybody that starts it on post-op day 0 or 1, but there's some variability in starting dose options. And so we have 3 different categories. Most people said they maxed out at a dose of 1,000 milligrams per dose. I recognize sometimes you'll push it higher than that, but most people said that was sort of acceptable to them. And then that centers had sort of different goals for when people come off of MMF. I think MMF is not something you guys use as standard here post-transplant, is that right? But at UCSF, for example, we almost never use basiliximab and thymo, but everybody gets started on MMF immediately after transplant. So that is a variability in practice that we think works well for us, but is not necessarily evidence-based. It's based on just how we've always done it. And so hopefully these kind of sort of reducing the variability will give us a chance to look at that over time. Tacro was a really interesting one. As you guys know well, 95 to 100% of kids get tacrolimus. And this is my attempt at a very basic heat map. We asked people what their general goal tac troughs were in the months after transplant. We recognize this varies a lot based on the patients, right? And I do apologize. I know some of these may be a little bit out of date. You guys may have adjusted things since I wrote this down. But what we actually found was that there was less variability in sort of the stated goal tac troughs than in some of the other medicines. And we also recognize that a big reason that people use things like MMF or sometimes the antibodies is to try to reduce the toxicity of tacrolimus. So we decided not to have really specific menu options for tacrolimus, but actually, as you'll see a little bit later, to look at it as more of an outcome. And if we're using these adjunct medicines, then do we end up actually sparing people tacrolimus exposure or not really? Because that seems like an important sort of long-term thing that's tied to complications over time. Finally, maybe not surprisingly, corticosteroids were the hardest thing. Swati Antala from Mount Sinai really helps tackle this for us. And this is an attempted heat map at sort of dosing over time, as well as, whether dosing really lines up with the use of adjunct medications. It really didn't that well. And so it took us longer to figure out consensus categories on this. And as you can see, there are more options that we're starting with. I think this is one of the will be one of the harder things to figure out, what really works best if we can end up finding something. So in that first in-person meeting, we actually came up with sort of consensus drafts for everything except steroids. And we had to spend some more time talking about it to try to figure out what the categories would be. But this is where we ended up. So as you can see, these have ranges of steroid dosing. The idea is that people will kind of report at the time of transplant what their intention is, and then we'll also collect some actual dosing at what we thought of as kind of key time points after transplant. And I think the initial goal for this will just be to look at like what are the most common pathways that people do use. To try to see from there if we can distill it down to the total number of combinations you could have here is like 27 or something, right? Which you never have a study with 27 arms. So the goal of this initial kind of use for this is just to see, are there certain pathways that are the most common ones that people use? And could we then distill it down to a more limited number of options that people might be willing to agree to using? And the goal, I think, of steroids, as with tacrolimus, is to try to look at kind of cumulative exposure plus the complications that are related to that. So that's where we are with the consensus treatment plans. We obviously have drafts. We've met with 13 of the 16. No, we have plans to meet with 13 of the 16 centers. I think we've actually met with 11 of the 16 centers. We have a couple meetings coming up and a couple more getting scheduled. And then we're hoping to kind of finalize the drafts and then go back to each center and ask for sort of a consensus approval. Can you implement this? You know, can you use this and can you implement it? And then we'll also be building into the Starzl registry the ability to like record which category your patient is in so we can look at it over time. We're hoping to use these consensus treatment plans plus the partner roadmap to do some comparative effectiveness research in the Starzl network. And so we have just submitted this grant proposal to PCORI. We called it the Optimal Transplant Study. It stands for Optimizing Immunosuppression After Pediatric Liver Transplant. It'll be an observational prospective study using the Starzl consensus treatment plans. Aim one is, and it looks at comparative efficacy of these different immunosuppression options. Aim one is basiliximab versus thymo versus steroids only. And aim two is MMF versus no MMF. The primary outcome we designed is based on the split ideal outcome, which is like a composite primary outcome that includes measures of both child health as well as liver health. So things like and it looks at it at 1 year post-transplant. And so that again was designed based on like what's feasible to collect, but also are we really reflecting what patients and families told us was important to them? We're also going to look as aim 3 at exposure to other immunosuppression. So when we're adding on additional medicines, are we really actually successfully decreasing exposure to TAC and steroids? Are we getting kids off of steroids faster? And then some other kind of like burden of immunosuppression, things like how long do you spend in the hospital and how many medicines are you on at a year? That's an important thing to families, is how many medicines are you on? So we just submitted this on Friday, so we'll find out in July what happens, but that's sort of the goal, is to move towards this kind of comparative effectiveness research with hopefully this as a first example. But I think, as I mentioned before, there's other examples of how we could do this in immunosuppression or other things in pediatric transplant. This is just a little bit more detail about what the study would look like. So it'd be observational to start. We would try to enroll 500 kids over a course of 3 years. That's about 2/3 of the transplants done at Starzl Network centers currently. So we hope that would be feasible. And you can see some of the other outcomes we looked at here. And actually, PCORI is not perfect, but is, really thinking about what's important to patients and families and stakeholders, which, as you guys know, is long-term outcomes. So the total study duration would be 7 years with a primary outcome at 1 year and then follow-up of everybody through 3 years. That's not enough to know what happens to them in the really long term, but at least is a little bit better than that traditional, like you only have 5 years to do the whole entire thing project. So I think this is just a sort of overview again of what we hope to accomplish with this kind of work. We've actually partnered with Action as a heart transplant network, and IROC is the kidney network. In another engagement awards, which is a group of young adult transplant recipients across different solid organs who we're kind of like training to advise us on some of these programs. They're called the Transplant Advocate Partners. And the overall goal is to get to evidence-based best practices for post-transplant care and to ensure, and we borrowed this line directly from Improved Care Now, but ensure that the right care is provided to the right person at the right time, every time. Certainly aspirational, but I think we would like to try to do that. And that's it. Thanks.
We have plenty of time for Q&A. For anyone that's on Zoom, please pop your question. We're happy to answer it on your behalf.
I have some questions.
Yeah.
Great. I love it. So the research questions, are they coming from the patients, the census for patients? Because some of the questions that I see, I mean, I would be impressed if the patients are saying, I want to know about MMF.
Yeah.
So are the research questions coming from them or just some of the outcomes?
It's a combination of both, right? So ideally you have, when you're thinking of up the research question, then you're really getting ideas from the patients about what's important to them and helping them form the research questions. But it is a joint effort for sure. And so what we tried to do in partner was figure out what's most important to you. Immunosuppression definitely emerges as like a big burden on people's lives. As I mentioned, they wanted to know, why is it different at different centers? And then the impact of immunosuppression is really important to them. But I do think it's a joint effort between like the patients and families helping you figure out what's really important to them, and then us helping shape that into like a feasible research question.
Yeah, then my other question regarding specific, I don't want to take this over, but the other question regarding the immune suppression that I had is, one is from the initial collection of data, right, from all these centers, do you have any granular data to say, well, this center has less rejection, less biopsy, because that would be helpful.
Yeah.
Because then you can start building kind of best as opposed to saying, well, we're all going to be the same.
Yeah.
I'm wondering if you're thinking this as a first step to eventually having kind of immune stratification of patients, which I think is probably the best, as opposed to saying we're just going to all do the same for every patient, which whether it's living related or compatible, I mean, things are different immunologically, right?
Yeah.
Is there a repeat transplant or not? All these things, depending on the disease state that we're transplanting. So I think that, is this kind of a first step to hopefully reach that?
Yeah, so I think this is a first step, right?
Okay.
That this is a first step to try to reduce variability and allow for comparison across centers. If we can collect, systematic data on 500 kids, then maybe we show that one regimen is clearly better, but maybe we show that one regimen isn't clearly better. And then we dig into the specifics of what about for kids under 5? What about for biliary atresia kids? And so the goal is eventually to get, I think, to more personalized immunosuppression, or maybe it's immune stratification based on things we don't routinely measure. We did do, and we published, I think, last year, the sort of analyses of the UNOS and SPLIT databases, because when we started, we were like, we already have all this data, we should just look at it. And not surprisingly, it didn't show that like one thing was clearly better than the other. It also didn't, I think, collect some of the more granular data, for example, about dosing or about duration of medicine, and the farther that you get out from transplant, the less accurate it is. So we did do that retrospective data analysis. When we shared it back with people and said, okay, are you ready to change your immunosuppression practices based on this? The answer was no, this is not convincing enough. And so then I think this is sort of the next step to say, what can we do to be more convincing that they're and sort of try to build a better evidence basis that people will find more trustworthy. Yeah.
Hey, Michael Rothbaum. So can you maybe let us be a fly on the wall on some of these consensus meetings.
Yeah.
Tell us, you share us what you've learned, what maybe surprising. I imagine much more slides.
Yeah. We've definitely put a lot of time into it. And I think just not been afraid to sort of repeat things, like sort of repeat the discussion if we didn't get to where we needed to be. Definitely we tried to sort of prepare going in, right? So we spent a bunch of time like looking through the protocols and trying to sort the data in a way that kind of made patterns more apparent. To try to prepare for some of these meetings. And then I think kind of bringing people together repeatedly over time, for sort of example, in the working groups and like virtually and then in person, and then presenting back out to the network and really just like sort of wallowing in the process helped us eventually get through it. And I imagine we'll sort of still have to adjust things based on what happens. But there is actually from PCORI a lot of guidance, and we had some consultants in our engagement awards try to help us think about like, how do we provide different ways for people to give feedback and make them comfortable to speak up and that kind of thing. And having the parents on the leadership group actually also helped a lot, because we could ask them like, what would make people feel comfortable speaking up? Do we, we need to like, became clear we needed to like limit the number of doctors on a call with patients and families and actually have patients separate than their parents so that those folks could feel comfortable speaking up in different situations. That having like a call where everybody was speaking Spanish and the facilitators could speak Spanish as opposed to having an interpreter who could interpret in Spanish, like was really important. So those kind of things we definitely learned over time. I think it's probably a little bit different for every community also.
Can you talk more about the advisory board? I think it's like the group of 12 patients, caregivers,
Yeah.
and how you found them or special things you considered when you were building your community advisory board.
Yeah. We just sent out like emails through the centers and through the transplant families, the family advocacy group. And we tried to have one parent of a recipient and one provider who is not necessarily an MD from each center. We met with them, I think, quarterly to get their feedback. And, some people were really active, engaged participants, and some people were not. It's hard because I think that's something you just have to sort of see over time. Our approach for that and for the advisory board we built for Optimal also has been to like try to be as inclusive as possible and then sort of see how it goes. I don't know if that was very effective, but like I think the other thing we learned was trying to like meet people where they were at. So like some people could come to every meeting when we scheduled it, and some people were really interested in giving feedback but couldn't necessarily come to the meetings. So providing some space to meet with them separately, or making 10 minutes for a phone call with them was like we try to make that opportunity also.
Have you found anything that leads to sustainability? Like they're like voting with their feet, keep coming to meetings. Do they get like compensation for time? Is it like how you?
Yeah. So PCORI does structure in very specifically compensation for everything that you ask somebody to do. And so they did get compensation for coming to the meetings. Everybody who filled out the like learning feedback modules also got compensation. So that's obviously a privilege that we can't continue forever with everything. But I think that sort of recognition of really valuing people's time and it is important. And then I think, again, what we found was like the focus groups, the places where they could like come meet other people and have discussions, and where we allowed some time for that, even if it wasn't exactly all about like the goals of what we wanted to get out of the discussion, was really important. So that like connection with other people who are living the same journey as them was the most important thing, I think, to most people who participated.
Just seeing it all together. Presentations so nice.
We'll see. It's a lot of ideas still.
One of the things I really struggle with, and I just want to value your opinion, we know that a good proportion, as we know, long-term survival is expected, is that non-adherent group.
Yeah.
And I guess I'm just wondering if this is sort of like criticism or concern that when we do research, especially stakeholders, we actually obviously have the most engaged, somewhat privileged or available patients, but yet there's we don't know what we don't know.
Yeah.
So how do we ensure that what we're doing actually is applicable and relevant to our monitoring.
Yeah. I know it's a really good question. I don't think I have a great answer to that, except that we have to keep trying, and kind of coming up with better ways to do it.
And that group's not always a fixed group, right? Like,
Totally.
people come in and out of
Yeah.
that. So
Yeah.
you can have people that have been there at some point in time, to sort of capture what they had, what was relevant important to them in those periods where they were not engaged.
Yeah. I mean, one of the things we've tried to do is figure out, are there kind of people who might be able to bridge to that group of folks who are less likely to speak up or less adherent to things or less likely to stand up and say that. So I think some of the parents, we're hoping the young adult recipients like may be more appealing to engage with than I would ever be. And so can we kind of like build out that group so that there's people in it that are more convincing bridges than I might be, is one way we've been thinking about it. And then really listening to those folks when they say, you got to do a group on Spanish, or you gotta, just meet with somebody by phone call whenever they can make it, or that kind of thing. We're about to ask our young adult recipients, like, how should we recruit more people to this group? Because I think the strategies that I could come up with are probably like not that appealing.
Totally, I think this is a concern for all groups, and just when we incorporate the broader structure.
Yeah.
Whether incentives or the monetary things, that somehow people, not that you're trying to find it. But,
Yeah.
And also the work with SDLHs and the social determinants
Yeah.
of health, those are very vulnerable areas.
Mhm.
A lot of things are in the transplant.
Yeah.
Sometimes, I'm just curious to know if there was guidance from that broader structure that would help inform us.
Yeah, I think they do have a lot of guidance also about like more specific resources about how to make people feel included and how to like, I think there are like things we've also tried to do as you set up the group, or you have the group think together about like, what are the like sort of norms and expectations for this group and what can we expect from each other, and like trying to help people feel like valued members of the group. It is another thing to try. Yeah. Yeah. And then I think just flexibility, especially if you're, trying to include people who sometimes can make it and sometimes can't make it, or might have a lot, of other things going on. We're lucky in transplant that I think, and this is probably true in pediatric chronic diseases in general, right? That like all of those families have been through like sometimes when life is really predictable and other times when things change really fast. And so they have a lot of sort of empathy and understanding for each other. So not setting those really high expectations or barriers. You don't get kicked out if you don't show up for 3 meetings, but I can't say that we've solved that issue for sure. Hey, how's it going?
Thank you so much for the talk.
Yeah.
I was really interested in the grant you just submitted for the PCORI. You had mentioned like we hope that 500 enrollees is realistic. With an observational study, what are some of the perceived barriers you foresee to not reaching the 500?
Yeah.
Like what will be the issues?
I hope it's just like, I think getting the enrollment set up at all the centers, and sort of, we were talking about this a little bit before, is having participation in that registry become part of the workflow that you really think about for everybody, and then trying to make it friendly in a way that is appealing to people and not intimidating.
To the staff and not
Both to the staff and to the families, right? So like one of the things that other folks have found, the IBD community, for example, found that trying to enroll patients in a like randomized treatment trial at the time of diagnosis was really overwhelming for a lot of families, right? The oncologists clearly have figured this out, but in the IBD world, they found that to be a really major limitation to one of their trials, because it was like just too much to have people getting this new diagnosis and then also being asked to agree to like randomization of treatment, at least for how they were learning to do it. So I think one of the things we're aiming for in the optimal trial actually is to have people like set up processes where you're enrolling people in the STARSL registry, which actually will enroll you in the optimal study because it's all observational, sometime between like either during the evaluation or between evaluation and transplant. Because then you have usually, right, not everybody, you have your acute liver failure kids where there's 24 hours in between that, but for most people, the evaluation is like a lot of information, but sort of in a fairly controlled way. And then you have weeks to months between evaluation and transplant where the families may have a little more sense of like, okay, this is coming. And, then we may have space during a clinic visit or some other time to like talk about enrollment in this registry, as opposed to trying to enroll people on the day after transplant, where there's like a lot, or when they come in for transplant, where there's a lot of other things going on. And that's where, again, I think thinking with the patients and families from the beginning of when you're designing something to try to figure out, okay, imagine yourself back in this situation. How could we have made this like, okay for you, not overwhelming? What kind of information do you need? That kind of thing, something we're able to build in. We'll see. Still ambitious, but I'm hoping we can do it. To be honest, in the transplant world, like we collect observational registry data on everybody who gets listed and who gets transplanted. Like this is routine for what we do in transplant. So it takes a little bit of expansion for our mind, but to me, that's like, then we're expanding it into things that actually are more pediatric specific outcomes that matter to families. So I think it's getting comfortable with that.
Last question.
Oh, no.
Yeah, feel free to go if you guys have other things to do. It's okay.
Last question.
Yeah.
So I imagine you're gonna use some quality of life validated tools.
True.
Because I always worry with transplant studies, right? We're looking at, is the patient alive? Yes. Is the graft working? Yes. But we miss that the patient is missing school.
Totally.
Has 2 drains. I've had to do 3 RCPs, have come to IR.
Yep.
Has been hospitalized for this and that, has gotten all these biopsies. So we miss that.
Totally.
We just like, is the patient alive? Great.
Yeah.
Is the graft working? Yeah. And then we miss all that. And since this is more community based,
Yeah.
I hope that that's an important part of this.
Yes.
Right? Because
It is.
I know the surgeons only care about like graft survival, but yeah.
Thanks to Vicky, we have a validated Health QL. It's like a setup, right? So it's a quality of life tool.
That's right.
Yeah. So we're gonna.
We miss all that, right? I mean.
One of my best analogies, when the kids come in for their annual, going well, normal labs, ultrasound is fine, we do a fast physical body, but there's just so much that we really could be diving into, and so making comms, patient care implement is not just research focused, how we're so good with doing comms as part of the research, because there's research coordinators, but making it kind of like a balance. The beginning of saying that your patient voice really matters. Thank you.
Yes, you're right. Yeah, absolutely. Yeah.
I didn't prepare this.
I know. Yeah. And
I only dabble.
one of the other, so we'll have one about quality of life that's for kids and parents. We also put in something called the PedsQL Family Impact Module, which is meant to look at, because parents talk a lot about like the impact on the family and the siblings and work, and so it's actually a parent questionnaire that asks about some of those things. And then there's one about there's a couple questions about sleep, because people felt like, how do you, like, one of the ways they know if they're back to a normal life is if like the kid is sleeping through the night and also the parent is sleeping through the night.
Very good.
One question, but I had one comment was that it was really helpful when we did the one-on-one with you, when we looked at not only our data, but that heat map.
Yeah.
Like what stands out is like, we're the red group, like we're the group.
Yeah, sorry about that.
That's what I went like, that's
Like
what I
you
saw.
do chapter 12 to 15, we're the only center, and so to think about like the changes stage or the,
But, yeah.
what like change.
But that goes
stage
with what
change.
was said when we started here, which we felt like that was too high, but it was just a culture here.
Yeah.
So that's why we've continued with it, but
Yeah.
it's something that I think like showing this data, showing consensus can push centers
Yeah.
to start to make changes.
So that's what we were hoping a little bit, that just being transparent would sort of help people recognize where they were outliers. And then you can decide like, that's the right thing, we're gonna keep doing that. Or maybe we're an outlier and do we have a good reason for that or not? So we'll see. We don't know if that's gonna change things a little bit at all, but it is, I think, one of the benefits of just looking at what everybody's doing.
And then prior to starting your work, we would have said like, if we came and said, this seems a little bit high, but then we say, well, the reason we think we're doing it because we like need steroids so fast is like, it's better, like lower risk of infection. But in order to make like a big culture change, we'd have to look and see, do we actually have lower rejection or higher infection, lower, higher, et cetera? And so it does help to see the heat up to say like, we can and should be looking at data, but we also can align to like a broad, like these high performing centers, best practices.
That's the hope, right? That the Starzl registry is gonna have all that stuff baked in so that you can look at some of those things with some granularity if your patients are enrolled. So I think that's the other benefit is like it's trying to sort of do double duty, that this data is, will be used for research analysis, but it's also available for answering whatever questions are most important to your center in a way that's